going to show you median motor response, especially how to stimulate in the palm, which many of you do not do. And I suggest you do that. Am I okay to do? All right. Because remember, between the distal and proximal side of stimulation, it is the distal stimulation that counts. And when I say distal, it is distal to the site of the lesion. And in carpal tunnel syndrome, which is most common mononeuropathy, compression is here. Compression is not at the wrist. Compression is in the palm. And therefore, when you stimulate at the wrist, that's a proximal stimulation to me. And the proximal stimulation doesn't help you. You have to stimulate distal to the site of the lesion. Is that all right? All right, that's what I'm going to show you. Okay, but first, let me show you the regular. So let me just explain for those who have not seen this kind of thing. I have two recording electrodes here, right? Here, this and this. And one is called now E1. Remember, this is used to be called G1, grid 1 of the amplifier, but we don't have amplifier. So this is electrode 1, E1, which is the active electrode, which is on the muscle, abductor pollicis brevis. And this one is in the tendon. This is a reference electrode. And this arrangement is called belly tendon recording. Belly of the muscle, reference to the tendon. All right? Now again, if you have any questions, raise your hands and we'll discuss it, right? So this is how we do it. And now, stimulating electrode, again, has a two probe, 1 and 2. Yeah? Negative here, if you can see it, this negative is the cathode. Remember cathode from cation, but because this attracts cation, it's a negative pole, which is a stimulating pole, right? Under the negativity, if you close the switch, negativity accumulates under the cathode outside the axon, making inside more positive. That's a depolarization. And if that depolarization arrives at the critical level, what happens? Sodium channels open, and you have an action potential, right? All right, so that's how we go. And the rule is negative electrode facing the pickup electrode, right? Rather than the other way around. Negative electrode face the pickup electrode. And we stimulate 3 centimeters above the distal crease. That is the only landmark we use, 3 centimeters above, right in here. Okay? And I can control, can I change the negative? I can control the intensity. Instead, we are using Nihon Koden equipment, which came from Dubai with my friend, Alejandro. And we had a great difficulty this noon to control the interference pattern, interference here. Hotel room is notoriously bad because they are not grounded properly. And somehow we have figured out a little better. Okay, so you watch the screen here, and the intensity here, change it to about 15 to speed. Okay, so I'm going to stimulate, if I can.
Yeah, we can see
Okay. Okay. Now, what did I tell you this morning to do first when I stimulate? First thing to do is what? Huh?
Muscle twitch.
Yeah, very good. So did you do that? You are all looking at the waveform, but muscle twitch is over the right side. What kind of twitch is that? Let me see. You feel the muscle twitch? Or what is that movement? Abduction. So it's okay, right? I'm stimulating median nerve, right? And the waveform is over there on the left-hand side. Now store that. And I'm going now to stimulate the median nerve here. Alright? And I'm going to stimulate median nerve and you watch muscle. That's a different muscle twitch. You see that? What is this twitch? This is abduction. Obviously, because I'm stimulating arm and leg, right? But you see the response here. Why do I see the response? I'm on the abductor pollicis brevis. When I stimulate ulnar nerve, why do I get the response?
Volume conduction.
Yes, volume conduction. From which muscle mainly? Adductor pollicis, right? Which is under the abductor. So the thing you have to remember is that recording electrode is very non-specific. They record anything because the hand is a volume conductor. Whatever happens in the hand, they record. So looking at the waveform, you don't know where it's coming from. That's why you have to look for the muscle twitch. That's the theory. All right? So that's the main thing. Okay, erase that, and let me go back to the median nerve. So I'm going to stimulate median nerve once, like that. Now, let me try one more time with high intensity. I'll try again. And remember, there is a such thing as maximum and sub-maximum response. Usually, you start with small intensity, and as you increase the shock intensity, response grows until it plateaus. And that intensity is called maximum intensity. And we usually use 20% supra-maximum, indicating we add about 20%. Just make sure that you stimulate everything, right? And this is 20% supra-maximum, because if I increase the intensity more, it doesn't change, right? And this is what you take. So that. Okay? Now, I'm now going to move my thumb up a little, like this. You see that? I just moved up, but I'm at rest, and I'm going to stimulate again. See what happened? What happened there? Let me do it again, the second one. Yeah.
Duration becomes smaller.
What becomes smaller?
Duration.
Yeah, duration becomes smaller and amplitude
Higher.
becomes larger. Why is that? I didn't do anything different. You never thought of this kind of thing, right? When I move actually I'm shortening the abductor pollicis brevis. If you shorten the muscle, you know, this is what you record in the screen here, big response, is a compound muscle action potential. It comes from all the motor units in that particular muscle. That's why it's called compound muscle action potential. And when you shorten the muscle, motor unit potential becomes synchronized. If they synchronize, the duration becomes shorter and amplitude becomes higher. So that's why when you do repetitive stimulation, you have to keep the muscle in. Let's say one hertz, right?
Ah, yeah,
Let me make sure that. Let me show you something else. Okay, let me show one shot, right?
It's okay.
One
shot. Yeah, please.
One shot, just yeah, okay. But then you erase that, and you tell me when. 1 hertz, right?
Yes.
Yeah, okay. No, you have to do it in a.
Sorry, this is sorry.
Oh, this is the one,
Yeah.
okay. So what happened here? Oh, you erased it.
I will erase it from the beginning.
Okay, just a minute. Tell me when. Yeah. So,
Stimulate.
yeah.
Okay.
This one was not as bad as good, but that's okay. See what happened here? Is this normal? If you're doing a rep stem, is this normal or abnormal?
Repetitive installation.
Huh?
What?
You see the you see the amplitude change. This is big. You
So-
usually compare
pseudo-facilitation.
the fourth one here.
Pseudo facilitation.
What do you mean pseudo facilitation? Yeah, well, let me ask you: is this normal or abnormal? Usually, you consider this normal, right? Because there's 10% change between the first one and second one. You can see it in here. First one, usually you compare this to the third or fourth or fifth, and if there's a 10% change, it's abnormal. But this is not abnormal, right? Because it's me. I don't know my graph. So when you see this, you have to say this is technical. Now how can you say that? That is my question. How can you say that this is a technical problem without me telling you that it is technical?
Sir,
Dr. Mishra will be talking about this tomorrow more. But how can you tell that this is not good?
I think in the typical drop in the amplitude, we will see a U shape. That's that.
Yes, what you do,
That's
you see this U
you see
shape.
the drop in the fourth
Down, and it's
then
coming up.
I expect in the sixth or seventh there will be repairing, and we will see a typical U shape.
Yeah, but this is a U shape. This is perfectly U shape, down and coming up, plateau. So that is not the answer. What is the answer? When you look at this, when your resident come with this waveform, and he said, I have a decromantic response, patient has myasthenia gravis. You say no, and you say why? Just by looking at the waveform, why can you not accept this? Anybody? You accept this then? You think I'm myasthenic? Well, you don't accept because this waveform, initial one, and this waveform, the last one, is not the same. This is a short duration, and this is a longer duration, indicating muscle move. I just showed you before I did that. I say I moved my muscle intentionally. This was that thing, and I moved it down, 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 down. And so synchronization is different. Or this and this is a normal response, but the position of the thumb is different. One is synchronized, and the other is desynchronized. You follow me? But vis-a-vis, you can forget about everything, but you got to remember that the muscle has to stay in the same position when you do repetitive stimulation. Otherwise, whatever you measure doesn't count, right? Yeah, that's why we always put the bar so that nothing moves. All right, so that's fine. Okay, let's go to the regular study. And I showed you already median response and ulnar response, and that can be used very effectively for carpal tunnel syndrome. You compare ulnar response and median response recording from the thenar images. And if there is a latency increase more than 0.5 millisecond, that's always abnormal, right? If median latency is greater than ulnar latency by 0.5 millisecond. And sometimes you see 2 millisecond difference, huge difference. So that's one thing we do. We always try to compare one nerve to the other nerve, which is a good way to do it, right? But now let me show you, before I go further, how the thumb is stimulated. The median nerve is stimulated at the palm, which is not very. Sometimes, unless you know what you're doing, it's not an easy thing to do. But you learn it. So again, the pickup electrode is the same. I'm going to stimulate. Give me about 20, 25 to speed up. Okay. So I'm going to stimulate here. Now this time, I'm going into the sun. So cathode is up. Remember, principle is a cathode facing the pickup electrode, not the other way around. Because under the anode, you may have hyperpolarization. Actually, it doesn't happen, but theoretically, we don't like it, right? So when I stimulate way over here, which I'm going to do, very distantly, I stimulate. Do you have sound?
Yeah.
Put the sound. See, I'm not used to this. See, I stimulated, I felt it, and so shock is gone, but nothing happened, right? No movement, right? Okay, now I go more proximally around here. You see the movement? You don't see movement because you are not looking.
The video camera.
Let's see it again. What is the movement? Huh? Adduction. See, and then there's the response there. That's ulnar nerve, which we don't want, right? Because we are doing median nerve. All right, I move 1 centimeter more proximally here. Okay, you watch sound. You see the change in twitch? This is a median twitch because this is abduction. That's how you know this is a median nerve. Not because of the response. I mean, response is good for median nerve, but it is a twitch that tells you that this is a median nerve you're stimulating. That's why it is important that you watch, right? If I stimulate the ulnar nerve, I can stimulate the ulnar nerve here. So that's how the median nerve is stimulated in the palm. Did you get that? Most of the time it's easy. 80% of the time it's nothing. 20%, 15 to 20% of patients, movement is a little difficult to assess because there's an opposition too. When the thumb opposes, sometimes you don't know it's adduction or abduction or what. Sometimes, so there are some difficult hands. But most of the time, this is fine. We do this routinely, and I suggest you do that too. Okay? Any question about this? Remember, it's a twitch of the muscle. Let me show you one more time. Just to see. This is ulnar. This is ulnar movement. Is there ulnar nerve here in the palm?
Deep ulnar branch.
Yeah, of course there's ulnar nerve. It has to go down. It has to go all the way around to the first osseous. But if I go 1 centimeter above, movement is very different. That's abduction. I can see I know my hand very well. I stimulate every day, so I know where the nerve is. But it can be done very, I say, easily. All right, so much for the. Any question about this? Let's move this to the lumbricus. Now I'll tell you another recording site for median nerve. That is the lumbricus. All right, this is Shapiro, Preston Shapiro technique, which I like. I like particularly for inching technique for this move. But you can stimulate. Well, let me ask you, how many lumbricus are there?
Four.
Very good. First two. Median and last two ulnar. And I'm here, this one is on the second lumbricus. First lumbricus, I don't know whether, first lumbricus is here, second, third, and fourth. So this is the second lumbricus, right? But it is also on the third palmar interosseous. Well, let's see. How many interossei are there? 4.
Seven.
4 is the correct. Huh?
Seven.
4 dorsal.
3.
And 3.
Balmer. 4.
You shut up. Let me ask this guy. 4 dorsal and 4 and 4. That's close, but incorrect. Anybody 4 and
4 dorsal and 3 palmar.
For palmar is 3, right? 4 dorsal, 3 palmar. You need to know this. And in addition, I think you need to know dorsal interossei are all abductor. Did you know that? The first one, am I on the? Oh, okay. This one. Okay. Dorsal interossei is. Okay. First, dorsal interossei abduct the index finger. You know that, right? This is the first one. Abduct index finger. Second and the third, dorsal interosseous abduct the middle finger. Because movement of the middle finger one way or the other is abduction. Remember, abduction by definition is a deviation from the center. So when the middle finger moves this way, by second dorsal interosseous, that's abduction. If it moves to the other direction by the third interosseous, that's abduction too. So 1, 2, 3, and the fourth dorsal interosseous abduct ring finger. So dorsal interosseous are all abducted. You got that? In contrast, palmar interosseous are all adducted. First, there are only 3 of them. First one, adduct the index, and then you skip the middle one, and then you have the next one, adduct the ring finger, and the third one, adduct the little finger. All right? And this electrode, which I press here, is on the second lambricalis and first palmar interosseous, which is ulnar. And therefore, you can now record from both median and ulnar. Is that all right? And we do that too. Okay, so this is how it's done. So let me show you.
20.
Yeah, motor, right? So let me show you the. Okay. Let me show you the median nerve first. And I'm going to stimulate. 20. Okay, give me a higher gain. I don't know. Okay. Is this what is again? 1 millivolt?
1 millivolt already.
Oh, I should have a better response. I think my nerve is getting tired. Oh, but that's okay. Okay, take that. All right, now I'm going to stimulate the ulnar nerve. Like that, right? Okay, and you compare the latency. And again, anything more than 0.5 milliseconds is abnormal here. All right, and this is a very good way to do it. Now I have a question here for you. Okay, yeah. This is my median response, right? And this is the takeoff. Now what is, and that matches with ulnar latency, more or less exactly, right? What is this little guy here in front of it? You need to know it so that you can ignore. But I think it's good if you have some kind of name to it. What is the name here?
Motor artifact.
Huh?
Motor artifact due to muscle, other muscle activation.
You are wrong in 2 accounts. First of all, I'm asking you the name, and it's not called motor artifact. This is not artifact. What is it? This big one is called motor potential. You know, it has many names: M response, CMA, CMAT, but usually it's called motor potential. So what would you call the little guy in front of it? What is in front of? Very good. Who said that? Pre. Yeah. So in front of, and then pre what? In front of what? Pre-motor, right? So this is called pre-motor potential. That's a name you have to know to ignore it. Don't measure the latency in front of the pre-motor potential. All right? You gotta measure it here, ignoring. And there's a lot of debate about what is this, but it is related to the nerve action potential before it enters the muscle. And this is very complicated. I know exactly what it is, but I don't want to tell you because it takes a lot of talking. But I think it's important to ignore that when you're doing clinical study, okay? But its name is premotor potential, and it is not part of the motor potential. All right, so let's do the eating here. eating now.
So I will delete this one.
Delete everything and I need the last sample. Let me show you something else we do here. Often. That's right. Okay. So let me use 25 maybe or less, maybe higher. Okay. Can I try it?
Yeah.
Let me do this and then explain. Stimulus output. Maybe the whole take it. Stimulus output. This is not the ideal place to do. So you can stimulus output, take it. Stimulus output is a little too much. Okay. Well, just let's start from the beginning. I think I need to control the stimulus output a little bit if I can. Maybe I cannot. Okay, let's start. Okay. Okay, take that. Take that. Take that. Take that. And take that. Eating study is done like this. I just followed Alma there. And usually at home, our technician measures it 1 centimeter apart. Yeah, today I don't measure. And I'm moving the width of this simulator, so it must be around 2 centimeter, 2 centimeter apart. But then, I mean, eating is not, if you know where the nerve is, you just go along the nerve with certain distance, either 1 centimeter or 2 centimeter, right? You can probably use, yeah. And you see in the bottom, the first one is not a very good response here because stimulus artifact is not controlled. The rest is pretty good, and this marker should be moved here. Can you move it? No.
I will move it.
Yeah. You see where the takeoff is? Takeoff is a little difficult to see, and this one is probably around here. And when you eat like that, it should be linear. This marker should move linear. And it's moving linear. When you see this, the separation is the same. Are you following me? Okay, let me ask you a question. If you move the cursor, as we did, every 2 centimeters, what is the latency change every time I move?
How much?
2 centimeters. As I did, this is 2 centimeters.
0.8?
4.4.
0.4
Right.
every 1 centimeter. Yes.
2 centimeters, 4.4. 0.0. Every time you move 2 centimeters, that's 0.4. Every time you move 1 centimeter, how much? 1 centimeter. This number you're going to remember. When you move 1 centimeter,
0.2?
0.2, right? Because nerve conduct 50 meters per second. If you divide 0.2 millisecond by 1 centimeter, you get 50 meters per second. This is the other way around. Sorry, 1 centimeter divided by 0.2 millisecond. And if you adjust the unit, it becomes 50 meters per second. So every time you move, so every time you move 2 centimeters, then it should jump 0.4 milliseconds. You follow me? If it jump more than double, that is 0.8, that's always abnormal. But we usually do it 1 centimeter apart. So it goes 0.2, 0.2, 0.2, and then if it goes 0.5, that's abnormal, right? Now, this kind of thing, of course, the electrode, there's a placement error. So it's not always 0.2 exact, but it's good enough. And then when it jumps, it can jump, believe me, in carpal tunnel syndrome or when there's ulnar compression, it really jumps, 0.2, 0.2, and then it goes